A big warm welcome to the TB Multimorbidity Network meeting. And our focus on this meeting is TB and diabetes, changing policy and practice. We have a really good lineup of speakers. We realized I didn't actually introduce myself. I'm Helen Elsey, and I'm a senior lecturer based at the University of York, working with the TB and Multimorbidity Network, which is led by Dr. Najma Siddiqui, and also with Kamran Siddiqui in York. Alexander Hirade is the researcher working on the project. So that is all from me, and we have a whole range of speakers coming up who I'll introduce as we get to. But I want to start by with a tribute to the late Dr. Dost Muhammad Khan, who was from KP province in Pakistan, and Dr. Dost has been a fantastic resource and lead in TB in KP province, but in Pakistan, particularly on work that we've done in York around TB and tobacco. Professor Yan Lin, who is the advisor from the union, focusing particularly on TB and diabetes. Professor Yan, please go ahead with your presentation. Thank you.
Thank you very much. Thank you for the introduction. Can I have my next slide? Okay, thank you. So today I will give a very brief overview on bidirectional screening of TB and diabetes, where we are and how to move forward. So you all know this strategy is one of the strategies recommended by WHO and the Union. So in the WHO and the Union collaborative framework for care and control TB and diabetes. So this is one of the major strategies recommended by WHO and the Union. And after that, in 2019, also emphasized in more technical detail on how to screening the target people and the key factors related to screen in the technical guide issued by the union in partnership with World Diabetes Foundation last year. Next one. So let's start from the easy one, screening TB patient for diabetes. Next one. During the last decade, there are a lot of research come out in this field. This research demonstrated two issues. One is screening diabetes in TB patient is necessary. I see no wonder in which settings, like in China, in Uganda, in some other countries, we find a larger percentage of the detected diabetes case are newly detected. So that means if we do not carry out the screening, these people never been diagnosed, even they have diabetes. And also the research demonstrate the screening is feasible. Like the screening was carried out in government health facilities, in private sectors, and in resource limited settings, all demonstrate necessary. Currently, in the global level, the prevalence of diabetes in TB patient is about 15%, but it's varied from 0.1% to almost 50%, varies in some countries and regions. In some countries like Asia, the Southeast Asia, Caribbean region are higher than that in some other regions. Next one. Next one. And the research carried out, the previous one. The previous one, why I cannot move it? Okay, thank you. In the screening, you know, a lot of research demonstrate why the screening changed, you know. The next one, yes, thank you. The screening, you know, no wonder in which settings we find the prevalence of diabetes in TB patient is generally higher than that in general population in the same catchment area in the same time. So this is again demonstrates the need to carry out the screening in routine program settings. Next one. But there are some operational issues we met. One is, you know, what is the best time to take blood samples? And to answer these questions, we should know if the blood sugar level is stable or fluctuant during the 6 months anti-TB treatment. So this comes to the crucial question, taking one blood test is enough to diagnose or rule out diabetes for majority of the TB patient. Next one. So for answer this question, we carried out operational research in this is a multi-center research to see the blood sugar level change among the TB patient during the TB treatment. So we find the majority of them, the blood sugar level is change no wonder up or down, but is within 1 millimole level. But a certain group of people have an unstable blood sugar level. So in the multivariate analysis, we find several risk factors for patients have unstable blood sugar level. One is HIV positive patient. Compared with HIV negative patient, so this is one of the identified risk factors. The other one is patient already have diabetes. And the next one come to smoking. So compare with the non-smoker, the smoking TB patient is one of the risk factors for have unstable blood sugar level. And interestingly, the patient presented to hospital is more frequent have unstable blood sugar level compared with people presented to the TB clinic. So this again demonstrates some of the infection-related hyperglycemia. So next one. So this finding suggests in resource-limited settings, if patient the fasting blood sugar level at the beginning of TB treatment is within the 7.0 millimole, so do not need to be closely followed up throughout the treatment period. As early detection of the diabetes can improve the TB treatment outcome and also benefit to blood sugar level control. So we recommend the screening to be performed, you know, immediately after the TB notifications. And certain, you know, factors for people have a unstable blood sugar level. So this kind of patient need to be close follow-up during the treatment. Next one. Currently, in the management of diabetes, the TB guideline, so we recommend all TB patients should be screened for diabetes or targeted approach if resource is limited. And fasting blood glucose level and HbA1c is the preferred text in program settings if possible. And blood sample taken at the time of TB diagnosis and get a confirmation test by the end of continuation period if possible. Next one. So we come to the screening diabetes for TB. This is more complicated. Next one.
Dr. Yan, you have 1 minute left, I'm afraid.
So we again find in the program setting, this is feasible. Next one. But there are some sensitive issues. So we find compare with the screening in hospitals. So screening in community health center have a larger percentage of the patient with symptom, but a small percentage of them getting finally confirmed. Next one. So again, there's some operational issues. On top is very busy for diabetes doctors and the lack of awareness and no diabetes program in most of the low and middle income countries. And the doctors, as the diabetes doctor, not often attending, public health work. So it is difficult to get them, spend too much time on this. And also there's no electronic record. So bring the patient calculation issue. Next one. So how to move forward? Still need to improve knowledge regarding to the linkage of this disease. So need a close collaboration between the programs. Currently, the screening should be exactly carried out in the settings with TB prevalence greater than 100 per 100,000 populations. So still need the screening target some risk factors, such as people with poor blood sugar level control, and more targeted screening to newly diagnosis of diabetes. In the rest of the time, need to educate diabetes patients to see doctors if they get TB, symptoms suggestive of TB. So this is a major one from me. Thank you very much for your attention. Thank you.
Thank you, Professor Yan, for keeping to time. That's fantastic and very useful overview, I think, of many of the issues. So if I could now move to Tanzania, and we have Professor Kaushik Ramaya, who is the General Secretary of the Tanzanian Diabetes Association.
Thank you very much for giving me this opportunity. And I'll be talking about TB and diabetes changing policy and practice, the perspective from Tanzania. Next slide, please. The National TB and Leprosy Program was launched by the Ministry of Health in 1977 to fight TB and leprosy in Tanzania. Since then, the program has joined hands with international and local development partners in an effort to prevent and control TB and leprosy to the point that they are no longer a public health concern. However, TB has continued to be among the top 10 causes of death and among admissions aged 5 years and above in the country, suggesting even a greater degree of urgency to fight the disease. Next slide. In 2018, total of 75,845 cases of all forms were notified, which is an increase by 6,205 cases or 9% compared to the year 2017. New and relapsed TB cases notified were 74,692. Among them, 48% were bacteriologically confirmed TB cases, while 79% were pulmonary TB cases, and children among the new and relapsed cases were 14%. TB continues to be among the top 10 killers, costing the lives of many women and children. Next slide. If you look at this slide, which shows the National TB Leprosy Program towards the End TB strategy milestones as directed in 2018, you find that the incidence rates reduction have not achieved around 18%, death reduced by 27%, while the milestone was around 35%. Knowing HIV status is where there has been a maximum sort of an output whereby 99% of all the HIV patients know their TB status. The treatment coverage is around 53% as compared to 90%, which was earmarked. Percentage of TB diagnosed using rapid tests was only 18% compared to more than 90%, which was recommended. And then you find DSTAG coverage and case fatality ratio also quite significantly different. Next slide. If you look at the trend of TB notification in Tanzania from 2012 to 2018, you find that the numbers have gone up from 63,892 to 75,845 in 2018. Next one. Looking at the co-burden or comorbidity, if you look at the prevalence of diabetes in Tanzania, if you look at the prevalence figures in 1980s, the rural population, the prevalence was less than 1%. In urban population, it was less than 2%. Special groups was around 5 to 6%. And Asian Indian groups was around 12%. The repeat prevalence studies in year 2000 showed prevalence of around 5%, and the STEP survey in 2012 showed a prevalence of 9%. And you find that this is where we are talking of the double burden, whereby you have an increase in the non-communicable disease, but at the same time, the TB also is increasing. Next slide. This is the data from the global prevalence of diabetes in active tuberculosis, a systemic review analysis from the global Lancet Global Health. And if you look at the data from Tanzania, from the publications which were in 2015, 2016, you find that the rates are around 9.1, prevalence 7.2. So you find that there's definitely an increase in diabetes and tuberculosis over a period of time. Next slide. Now, the interesting issue here is that from the Lancet Commission of Diabetes in Sub-Saharan Africa, if you find that the number of people with diabetes diagnosed in the continent, of 100 who are diagnosed, 64 of them are detected, 48% are diagnosed, 45% of them are treated, and only 30% of them are under good control. The reason why I'm showing this slide is that to explain to you that if you have a person with a diabetes which is poorly controlled in an area, then you might find that the tuberculosis prevalence, also the prevalence incidence would also increase quite significantly, because you are dealing with a population whereby for every one diagnosed person, there are 2 to 3 who are not diagnosed. And of those who are diagnosed, only 30% are adequately controlled. Next slide. This is the burden of disease in Tanzania compared from 1990 to 2017. And if you find in 1990, respiratory infection and TB was number 1. In 2017, the rank is number 2. But you find also is that other non-communicable disease, especially with diabetes and cardiovascular disease, as the number has been increasing. And this shows the trend of the double burden of the disease. Next slide. People with diabetes mellitus may be more heavily exposed to tuberculosis in our setting, may more easily get infected to TB given an exposure, have a high risk of latent TB infection, and have a faster disease progression if the diabetes is poorly controlled, and need to be screened for TB. And this may contribute to early case detection and reduction of transmission of the tuberculosis. Next slide. Amongst people with tuberculosis, diabetes will adversely affect the TB treatment outcomes. Diabetes may also accelerate the emergence of multi-drug resistant TB among those receiving TB treatment. TB medications may interfere with treatment of diabetes through drug interactions. Next slide. What are the policy interventions in place? Next one. We have a national strategic plan which is ending this year, and if you see that the number 1 on the strategic plan is to increase case detection by 29% by 2020 by strengthening the routine case notification, addressing vulnerable groups, including elderly, prisoners, minors, and the diabetics. And that is what I wanted to highlight, that it is a part of the strategic plan for ensuring that we have this comorbidity covered up. Next slide. We also have an NCD strategy. The first strategy was 2008 to 2015, which consisted of 4 components, which was health promotion and prevention, care and treatment, rehabilitation services, monitoring, evaluation, and research. And within this strategy, tuberculosis was not much covered. Next slide. But if you look at the next strategy, 2016 to 2020, we had component of advocacy, capacity and leadership, risk factors, health systems, research, and monitoring and evaluation. And within this strategy, comorbidities and TB and diabetes was significantly covered. Next slide. What have we done as a health system? Next slide. If you see, this is an assessment of the overall capacity of the antenatal staff of the training which has been imparted to them. And if you see, the TB training has been to about 60 to 70% of the staff. But if you look at the training on diabetes, hypertension, and other NCDs, it was less than 30%. And you find that there is a huge gap, which we identified that the healthcare providers at the primary care, secondary care, and tertiary care, the amount of training which was provided within the non-communicable disease was very low compared to TB, HIV, AIDS, and PMTCT. Next slide. And if you look at similarly at the CTC clinics, again, you find that the component or the coverage of TB was optimized at the dispensary level, at the health center level, at the hospital level. But if you come to the non-communicable disease, the coverage was very low. So if you are going to have a comorbidity screening done, screening TB for diabetes and screening diabetes for TB, you need to have your health systems and health infrastructure appropriately in place. Next slide.
We have 1 minute left.
Yeah, this is a program which we did in 2011, 2017, which we did across training of all the different healthcare providers on the RCH clinic, TB leprosy clinic, and these were trained as a part of the needs assessment which we found. And this is what was done in the year 2011 to 2017 to see whether we can have the comorbidities. Next slide, please. Next slide, please. Yeah, so basically this is the data which is shown previously, but I would like to go to the next slide since I don't have much time. Yeah, next slide, please. What are we planning to do? And next one, please. Sorry, next one. I think we are repeating the same ones. Yeah. So within the National TB and Leprosy Program, guidelines have been developed in 2017, 2018. However, there has been a challenge with dissemination and implementation of these guidelines on diabetes and TB. There has been no data and monitoring and evaluation, and multi-sectoral approach multi-sectoral approach has not been taken in place, and I think that would be the reason why dissemination and implementation has not taken place. Next one. So what is the way forward? The way forward is that, next slide. Next slide, please. Next slide, please. Yeah, I think this slide has been taken over by the first speaker. So I'll go to the next slide. What is the way forward for Tanzania? Within the next program, which we are running currently from 2020 to 24, we are focusing on primary care, integrating training at the level of primary care at health centers and dispensary. And we are also going to strengthen further secondary and tertiary care facilities, use community health workers and peer educators to basically drive towards the prevention and advocacy. Primary prevention at the school level will be considered. Community mobilization will be the key component with people living with the disease, and establishing sustainable training and retraining programs. And the approach we are going to have is the next slide, is have a common triaging at the primary level, whereby you can have, because of the shortage of the healthcare providers, have multitasking at the level, and basically do the screening at the primary level, at the triaging, common triaging, before appropriate referrals are done. Next slide, please. And I think I've finished. Sorry. So we're looking at the diabetes TB guidelines and revive them again, have a multi-sectoral approach, coordination between the National TB Program and NCD units at the Ministry of Health, look at the different research projects with policy implications, conduct operational research, do implementation, and monitor and evaluate. Thank you very much.
Thank you, Dr. Kaushik. That was really helpful presentation and great to see the progress and also the clarity on the way ahead, and thinking through that level of integration within health services and some of those challenges. I think that really brings many of the issues home, and I'm sure that many people on the call can relate to that. To where things are at in Tanzania.
Can I ask Dr. Yan? Thank you very much, Dr. Yan. It's a very comprehensive presentation that really enlightened us on the way ahead. You mentioned that you recommend, I think it must be the Union and the WHO, systematic screening in settings of where tuberculosis is 100 per 100,000. I think we need really to revise this recommendation, because if we focus only where TB is 100 per 100,000, we are going to exclude a good number of countries with moderate TB.
Thank you. I understand your question, your concern. Thank you very much for bringing this issue out. The recommended in the guideline is for systematic screening. That means intensive screening for everyone is only for the settings with the tuberculosis prevalence greater than this number. But for other kind of screening, like the target screening or some of the symptom screening or any similar approach, would be appropriate for any settings that is the appropriate, feasible, and need to be screened. We may have a chance to communicate later on. Thank you.
So let me please introduce Dr. Razia Fatima, who's the Chief of Research and at the Common Unit for TB, AIDS and Malaria in Pakistan.
Thank you, Helen, and colleagues in this webinar. And I'm very pleased today to discuss about this pilot of TB and diabetes guidelines in Islamabad with the collaboration of the Union. I'm also Vice Chair at the Union, and I'm very pleased to work with Dr. Yan for this pilot. Next, please. Okay, so the rationale. Pakistan, as you know, is a high TB burden country. And we rank 5th among total high TB burden countries around the world. And there are around 328,000 notified cases annually with an incidence of 263 per 100,000 population. As part of the NTB strategy, it is important to work for the comorbidities. And on the top, of course, is diabetes for us as well, because the country faces the challenge of double burden of disease, and among NCDs, diabetes is again is a point of concern for the country. For TB and diabetes, it is evident that the diabetes has a detrimental effect on the treatment outcome of patients with TB, which may hinder achieving the goals of the NTB strategy by 2035. Next, please. Okay, so this was the guideline draft that was shared. Again, I'm very thankful to Dr. Yan who asked us. And I think there were 2 countries where the guideline was piloted. One was Pakistan and one was Zimbabwe. So next slide, please. I will share, I will just give the background and then the process. So as we all know that diabetes mellitus increases the risk of active tuberculosis by a factor of 2 to 3 times and increases the risk of adverse TB treatment outcomes. And TB causes stress-induced hyperglycemia, which can worsen the control of diabetes mellitus. There is a published collaborative framework for the care and control of tuberculosis and diabetes, which can guide policymakers and implementers in combating the epidemic of both diseases. Next. Okay, so all TB patients, like this was the key recommendation in the guide, and I just want to go through it for all the colleagues present in the call. All TB patients should be offered screening for diabetes. If resource limited, then a target screening, for example, for those of more than 40 years may be considered. Fasting blood glucose and HbA1c are the preferred diagnostic tests for diabetes mellitus in patients with TB. Diabetes mellitus patients should be offered systematic screening for active TB only in the high TB burden countries where TB prevalence is greater than 100 per 100,000, as Dr. Yan mentioned. When systematic TB screening is done, it should be performed actively, that is, it should be provider initiated for new patients diagnosed with diabetes mellitus and should include a TB symptom screen and a chest radiograph if resources permit, followed by the expert, and if there are suggestive TB symptoms or if the chest radiograph is abnormal. Next. So there should be a heightened index of suspicion of TB in patients with already established diabetes mellitus and attending care. Treatment for drug-susceptible and drug-resistant TB is similar in persons with and without diabetes mellitus, but health workers should be vigilant about monitoring treatment response as treatment failure and recurrent TB are more common in diabetes mellitus. And people with both diabetes mellitus and infectious TB should be treated for at least the first 2 weeks and preferably the first 2 months just in the TB clinic. Next, please. Metformin is the first-line drug for the drug of choice for treating person with diabetes mellitus if medication is needed to control elevated glucose levels, and insulin may have to be considered if blood glucose levels are very high. People with diabetes mellitus and a history of previous cardiovascular disease should be offered low-dose aspirin and a statin. Patients with diabetes mellitus and TB need to be counseled about appropriate lifestyle management like smoking cessation, good diet and exercise during anti-TB treatment. Standard recording and reporting as well as sufficient coordination at the national level is of course required. Next, please. So now I talk about the pilot. Again, I want to mention part of my team who is Dr. Amna from the initiative. She was with us for this pilot and she actively coordinated with all the doctors of 3 hospitals. So we discussed with Dr. Yan that how should we go about for this guide. So the planned pilot was because we needed, representative of the tertiary care hospitals, both in the capital and also in the twin city, Rawalpindi, which is a mega city. So we decided that we should take 3 hospitals, 2 in Islamabad, that is Pakistan Institute of Medical Sciences and Polyclinic Hospital, and 1 in Rawalpindi, which is Benazir Bhutto Hospital. The time frame was April to July 2018. Next slide. Next, please. Okay. The printed copies of the guide were distributed to relevant health workers in the 3 hospitals. The staff were encouraged to use the guide in their routine work, and the focal person was responsible to provide copies to relevant staff and give orientation to identify which divisions or departments were relevant to the pilot. And they were all in communication with the research unit and Dr. Amna and provide writing feedback at the end of the pilot. Next. So we planned a feedback in June, and the collaborating lead, I'm again thankful for Professor Yan, who was here, and this reminds me very good discussion at Islamabad Club, where all the doctors were invited, and they were pulmonologists, endocrinologists, and medical officers of these 3 tertiary care hospitals, and they were invited for the feedback. So they were, next please, yes. So the particular attention for the feedback were for the specific questions that are relevant for our settings, like if the recommended collaborating mechanism is workable in the local setting, if the recommended screening approaches for the 2 diseases are feasible in the program setting, if the key points for management of the 2 diseases are acceptable to the clinical officers and easy to be implemented in the routine clinical work, if the recommended infection control measures are feasible and can be implemented in both diabetes mellitus and TB services, and if the recommended recording, reporting, and data sharing are suitable for your local circumstances. Next. So the particular attention was again to implement the recommendation, what is needed at the national level, that there should be a national coordination body. Anything missing, inappropriate, or any suggestion from these specialists, and the guide is useful or helpful? Is the language used in the guide easy to understand? And length of the guide, what about if it is too long or too brief? Next. Okay, so the follow-up meeting was held on 17 July 2018, again in the presence of Dr. Yan, and there was a discussion on all the feasibility questions. And there were quite a good feedback from all the doctors, like for Pakistan, it's a resource-poor countries, and we have large number of anemic patients. So in the guidelines, the need for HbA1c as a first choice need to be discussed. The glycemic control need to be monitored more frequently and more stringent for successful management of active TB. Availability of gene expert test in resource-poor settings, especially when we want to scale up in the periphery, it would need resources. More consultation by the diabetes expert for stringent controlling crucial in first 2 months. And 2 groups were missed in guidelines, which are pregnant women and lactating mothers and the extrapulmonary TB. So they thought that it also should be focused. Proper infection control should be done for diabetes screening for the active TB patients. So there's high index of suspicion in either case of relevant clinical laboratory work can help in controlling this cascade of care for both diseases. Next. Okay, so the number of, as we know, that is a reality, the number of patients with diabetes mellitus are far more than the number of TB, and the number of active TB patients newly diagnosed diabetes mellitus patient in diabetic clinic is also small. And the newly diagnosed diabetes mellitus patients should be screened for active TB, as hyperglycemia, especially in the initial months of diabetes mellitus diagnosis, increases the risk. So and all these factors need to be, kept when we talk about the scale up. And of course, at the primary healthcare level, we need more resources. Next, please. Okay, so the way forward now after the pilot was after the feasibility assessment, we at the National TB Control Program look forward to be involved in the countrywide scale up, which of course need resource allocation, as well as the engagement of peripheral facilities. So what we are doing with Dr. Yan, again, with his support, and we have developed a research proposal, which would be more focused on the operational issues and on the policy impact as well. And we will submit a proposal for the bilateral screening of TB and diabetes to World Diabetic Federation soon. And today I had a very good discussion with our new manager. She is Dr. Naseem Akhtar, and she was very willing to be as PI of the study. So this is a very encouraging way forward for us. Next. Okay, so here after this pilot, like in Pakistan and Zimbabwe, this was published, the guideline was published by the Union on 21st January 2019, and now it is easily downloadable for everybody. And I encourage all of you to have a look at this, and please try to implement it in your settings as we are trying to do it, as part of the scale up. Next, please. So here I want to acknowledge the Union, especially Dr. Yan, for the confidence and support to pilot this guide in Pakistan, and of course the Union in the guide to acknowledge Pakistan in the final published TB and diabetes guidelines. And of course, special thanks to the management of the 3 hospitals, PIMS, Polyclinic, and RG8, and NTB management, and of course, Dr. Amna from the initiative, who was actually part of our team. The next slide is actually a thank you slide, and you see Dr. Amna and myself and the group of doctors who were engaged in this pilot, and Dr. Yen speaking in a very powerful way with all the doctors. So this.
Can I pass to Dr. Khalida Islam, who's the Public Health Advisor for the ARC Foundation in Bangladesh. Thank you, Khalida.
Thank you so much. I would like to welcome you all to the presentation, where I'll be sharing just a brief overview how we are addressing the TB and diabetes patients with primary healthcare. What are the challenges and how we can move forward. Next, please. Yes. Just a brief overview to the health system. This is a typical picture of the rural village of Bangladesh, where we need to start with, or we are working with preventive, promotive, follow-up, and social behavior change communication, trying to create awareness, empowerment, engagement, with a very limited health care, which is mostly providing family planning services and EPI services. The frontline healthcare providers are the health assistant, family welfare assistant, and a group of healthcare volunteers. Next, please. This is the community clinic, which is covering 6,000 population in the rural area. Within half an hour walking distance, they are doing the screening, follow-up, counseling, and referring the screening positive patient to the next step. That is union level facility, union sub-center, or union health and family welfare center. I put the figure very small because in Bangladesh, for union level center, for healthcare, it is almost non-functioning for most of the healthcare services. But for family welfare services, they are providing good care of antenatal checkup and labor. Next slide, please. The primary healthcare, the last step of primary healthcare facility is at sub-district level. We call it Upojala Health Complex. On the left side of the slide, it is usually 50-bedded hospital. The picture of all the Upojala Health Complex is not as beautiful as I have shown. Many of them have been upgraded to 100-bedded hospital. However, the manpower, the budget allocation, the food allocation is not yet upgraded to 100-bedded. So the healthcare providers are struggling. On the right-hand side, it is the district hospital providing the secondary care, and below is the tertiary facility, the medical college or the specialized institute. Next slide, please. Just a very brief overview regarding the data. It's Bangladesh specific, which I have picked up from global report. The estimated incidence of tuberculosis is 221 per 100,000 population. The HIV prevalence is still low. It is 0.1 for 15 to 49 years age group. And the last survey conducted is in 2015 for the TB prevalence. Next slide, please. The prevalence survey, which has been conducted in 2015, we found that bacteriologically confirmed cases were 287 per 100,000 population. Smear positive was 113. The prevalence is increasing with age, more in male, and rate of HIV positive TB mortality is 0.12%, and MDR TB incidence is 3.7%. But I would like to draw your attention to the below data, where universal health coverage, it shows that we could cover only 75% of population. Case fatality rate is 13%. National TB budget is $80 million US. But the point is, government contribution is only 20 to 23%, and there is a gap of about 20 to 25% in this budget. And if we look at the TB cases attributable to 5 risk factors, we found that diabetes is quite high. Next, please. The TB control program, it is a vertical program. It is doing good. The program started in 1993. It is implemented with NGOs. About 24 NGOs are working. The program is developing the guidelines, policy documents, doing the mobilization, social mobilization, doing the procurement, managing the supply chain, and doing the monitoring evaluation. The strength is the implementing partners. Government is trying to cover 100%. The service is decentralized, and the Bangladesh regime, which is shortened, it is good. However, there are some challenges. Treatment discontinuation is most important challenge, and we cannot calculate the accurate estimate. We don't have. Childhood TB is a problem. No coordination with private sector. There are vulnerable populations like garment workers, slum population, prison inmates, and there are many hard to reach areas in Bangladesh, pocket areas where we fail to reach. And urban population, reaching them with TB service is a great challenge for Bangladesh, because the budget is inadequate. Like rural infrastructure, we don't have any established infrastructure for urban area, and government support, how we can increase that. It is a very serious question for us, because Bangladesh is developing to is a stepping to a middle income country, and the budget for overall health system is very low. Next, please. But we are having a very good system for diabetes care. As we know, we have Professor Ibrahim, who established a tertiary hospital and a whole network of service who are taking care of diabetes patients all over the country. It is a very good infrastructure and support service for diabetic patients. Next, please. However, how we are providing care to patients with diabetes and tuberculosis currently in the country. The non-communicable disease control program, they are providing care at primary healthcare setting at Upazila Health Complex. They are providing NCD care, especially non-hypertension and diabetes, through NCD control, NCD corner to every Upazila Health Complex. However, they don't have any coordination with the DOTS clinic, which is situated to other part of the building or to the next building. The NTP, National Tuberculosis Program, as I said, they are implementing program through 24 NGOs. They have DOTS clinic, about 62 clinic which are supported by BRAC. They are doing blood sugar screening. However, there is no coordination. They are not referring those TB patients with high blood sugar to any NCD corner or BADA supported center, and no reporting of diabetic patients to the National Tuberculosis Control Program. The only ideal situation is BADAS and ICDRB supported program. They are trying to provide healthcare comprehensively in their clinics. This is a BADAS ICDRB supported clinic. They are screening both TB and diabetes patients, providing comprehensive treatment and reporting to the NCD control program. The most important part is private sector, which is totally out of coordination. They are treating TB patient and diabetic patient totally separately, no coordination, no reporting, and we don't know whether what regime they are following and what protocol they are following. We don't have any control over this private sector. So this is the most important area which needs coordination. Next slide, please. So if we look at the current existing programs, the private sector, they are isolated, they are treating their patients of their own. So we need to establish a mechanism so that they coordinate with the National Tuberculosis Control Program. They report and they provide they follow the national protocols. The government NCD corner of the non-communicable disease control program, they are treating diabetes and hypertensive program, hypertension patients. They need to coordinate with the diabetes, with the DOTS clinics. They need to do some sort of screening of the diabetic patient, and those who are diabetes screening positive, they need to refer them to the DOTS clinic. And all the patients from these centers of NCD need to attend the DOTS clinics who are positive, screening positive. And all the positive patients, then their data should be reflected to the national dashboard. So most important thing for Bangladesh is coordination. We need to coordinate DOTS center with NCD center so that diabetes patients are referred to DOTS center, or tuberculosis patients are referred to NCD corner for diabetes. We need to develop a comprehensive strategy so that no patient should be missed out. We need to share all the data to National Tuberculosis Control Program dashboard so that we will have a clear understanding of the disease burden. We may establish some executive clinic to share cost, because we know out-of-pocket expenditure is very high in Bangladesh. It is latest data is showing it is about 67% in 2 years back. Currently, it is about 73%. And not only that, we have to find out the mechanism how health facilities can utilize this cost, which can be recovered from the patients, well-to-do patients, because a large number of well-to-do patients, they don't want to be to take care in the government facilities. More importantly, we need to work on community level to create awareness among the patients, and we have to work against stigma. A girl, adolescent girl, her father never want the other people to know that she is suffering from diabetes or she is suffering from tuberculosis. So we have to work in this area to remove the stigma, and increasing accessibility is important, especially for the urban population. Nowadays, the latest data shows about 39% population is urban dwellers who are mostly floating, who are slum dwellers, who are non-registered or not getting primary health care in the urban areas, because in urban area, primary health care setting is very poor for Bangladesh. So we have to work in these areas, and all the vertical programs are there. We need to coordinate among the vertical programs. All the pieces of the puzzle is there. We need some extra effort to put the puzzles together so that we can address patients with TB or diabetes comprehensively. Thank you so much.
Thank you, Dr. Khalida. I think it was a really helpful look at those kind of wider health systems issues of the linkages between the public and private sector, and the importance of reporting and data sharing to do that, not only to understand the sort of burden of disease, but also just for individual patient management and referral and back referral. So thank you very much for highlighting those health systems issues.
So my name is Dr. Luz Nieves. I am an infectious disease epidemiologist and also a university professor. But, most of all, I think that one of the best things that happens to me was that to have a change in my life. I am a TB survivor, and I am a proud TB survivor. And you say, what? You have TB and you are proud of being a TB patient? Well, you're going to know my story, and then you're going to know why I am a proud TB survivor. So next. Yes, so this is, in a nutshell, this is the short life story. In 1987, I was working as a professional nurse in the ICU unit, and I was exposed to a undiagnosed TB patient. And I stayed with that patient for in three shifts, 8 hours each, enough to be, exposed to a patient that was undiagnosed and the patient had TB, but nobody knows that the patient had TB. I have a positive test with a 60 millimeters in November 1987. And in July 2008, July 2019, no, July 19, I'm so sorry. July 1988, I was diagnosed with TB. And I was 23 years old when that happened. Sorry for the typo. Next. So the time interval from first symptoms to final diagnosis was 2 months. I have, very, very strange symptoms, especially the pain in my lungs while walking. And I said, what happened to me? I was always in a very good shape. And I said, why when I walk, it hurts so bad? And, it hurts to breathe. And I feel this stabbing pain on my lungs. So, and things start getting worse. I start having a very high fever, severe cough, chest pain. Then after 2 months, I've developed a pleurisy on the right lung, and then I got lingular lung pneumonia. My saturation was 70% of room air, and then I have a very, very bad case of shortness of breath, and I was admitted to the hospital immediately for the second time. Next. So the clinical intervention immediately was the pleural tapping. They pull out a lot of fluids from my right lung. Then after that, 4 days later, the doctor still doesn't know that I was a TB patient. They still haven't diagnosed me, and they did a pleural biopsy. They thought I had cancer because, you know, when you have that kind of a pleurisy in a young patient, and they didn't match the connection between healthcare worker and having a PPD test conversion to 60 millimeters, they didn't did that, you know, connection. So, and then after that, they diagnosed me. The pleural biopsy came back positive for TB, and I had a 9-month TB treatment with rifampin, INH, vitamin B6, a lot of rest, and out of work for 1 year. It was kind of difficult for me, because since they don't knew that I was having TB, I was 2 months wandering different places, going from side to side, going from doctor to doctor, and no one was able to diagnose me. Next. Now in 2013, I was diagnosed with type 2 diabetes. I have my glucose control with medication, diet, and exercise. I have a strong family history of diabetes. My whole family from my mom's side, they all have diabetes. So next. So what is the discussion points here that I want you to bring this information to all the research experts, doctors, you know, coordinators, clinicians? The time to diagnosis from the symptoms to the diagnosis was 2 months. Thank God I was in a very good shape. You know, I have a very good health by that time, and I now, thank God. But that is too long, too long for diagnosing a patient. The physicians were unable to have a clear diagnosis. They told me that I have mycoplasma pneumonia. They told me that I have lingular lobe pneumonia, but nobody pinpointed that it was TB. So I have 2 hospitalizations, and this is an important point, that my first one was 7 days on a regular ward, a TB patient with no protection to other employees, no protection to no one. And I spent 7 days in the hospital coughing and puffing everyone. So, and that is a very good point, because that's why a prompt diagnosis and treatment and isolation is so important. The second one, since I was, they didn't know what I had, they placed me on isolation just for precautions. Next. So the discussion points here is that I was diagnosed with, I was an LTBI with no TB prophylaxis after conversion. I didn't receive any education about TB as a disease. I didn't receive neither any education about medication side effects. And that was one of the things that really worries me, because the side effects were kind of brutal on me. But I keep fighting, and, thank God I passed that step. No education at all about TB whatsoever. They told me, you had TB, you need to take this medication for 9 months. I'm going to see you in the office every month. You need to have sputums every month, but that's it. No education, no liver enzymes, no x-rays, nothing, just that. So then, now that I was diagnosed with diabetes, even I was followed by a diabetes educator and a diabetes program in a well-known, research institution, and also a hospital. There's no education about diabetes and TB. What is the point here? Living with TB was something that really changed my life. Now that I have diabetes, it's also a thing that I have to follow, because this is something that you're going to have for life. This is not going to disappear. And you need to have a good, tight, glucose control. And you need to, follow a very healthy lifestyle. And you have in your mind that you are a LTBI patient now, that you had TB in the past, that you have chronic changes in your lungs, and now you have TB. And then that is going to, that is something that you are not going to take out of your life, that you're going to live with that, and then you need to work with that as well. Next. So what is the takeaway? The takeaway here is that patient education is fundamental. You know, when a patient is diagnosed or when a patient is a rule out TB, they need to educate that patient and let them know what is happening. And then after, if the patient is diagnosed, the patient needs to be educated. You know, what is going to be, you know, TB from now, you know, and what is going to be the next steps that the patient needs to follow. Physician training, nurses training, you know, medical healthcare workers training is necessary, is imperative. It's very, very important because they are the ones that are going to take care of the patients. And if they don't know how to take care of the patient, if they don't know how to protect themselves, that is going to be a big problem or spreading the disease unnecessarily. And then also, for me, employee safety is non-negotiable. Employee safety is very important. That's why the prompt diagnosis of patient with TB, rule out TB, is very important when the patient enters that facility and the patient, you know, they have the minimal thought that the patient can have TB, immediately start that patient on isolation, negative pressure, take the precautions, do the test, you know, do the evaluation, you know, all the consults in order to see TB or not TB. It's very important because we need to protect, you know, the healthcare professionals. Those healthcare professionals have families and they need to protect their family as well. For me, it was not an easy ride, but thank God I have the support of my family by that time. I remember my mom, she passed away last year, but I remember that she was my big supporter and my other friends, you know, from my work. And next. So for me also, not all is lost. As I said, TB changed my life forever. I became a TB educator. And then after that, I became an infectious disease epidemiologist because I remember that day I was like 104 degrees and I was so sick that I thought that I was going to die. And I said, God, if you take me out from here, I am going to go on a mission that no healthcare worker is going to develop TB because of lack of protection. I work with TB patients. I call them my TB friends, my TB sisters and brothers. I had the opportunity to work for the county as a TB specialist and also, you know, running the TB clinic in my county. And also I'm a faithful advocate for TB patients in the US with the US government senators, talking to them, explaining to them my story, and then let them know that we need funds for education, that we need funds for research because TB is real. And this is something that we need to cope every single day. And also I'm a subject matter expert for healthcare workers in TB protection. I'm a TB consultant. I'm a proud member of We Are TB. And also I'm a proud daughter, mom, wife, professor, and soon to be grandmother. I just knew this last Saturday that my daughter, my beautiful daughter, is gonna have a baby. So this is a story. This is for me at the beginning, I didn't understand why that happens, but I turn around the situation and I make the situation that, you know, I learn from them, but then I want others to learn as well. And I am most thankful, Helen, thank you for the opportunity and for the organization. And thank you for the opportunity to share my story as a TB patient and also a diabetes patient. Thank you so much.
Thank you so much, Dr. Nieves. That was a really powerful, and to hear about those experiences in the US system, right? So
yes,
really, really valuable to hear those experiences, and many good lessons, I think, as we're thinking through these issues, and just to have that perspective as a patient, but also as a healthcare worker, I think is really helpful for our group. So thank you so much for your contributions. Really appreciated.
Yeah, thank you very much. And I am glad to join this, webinar. It's a very important webinar and, to change policy and practice and bring the two diseases together. Next slide, please. So briefly, I will touch on the global burden on TB and diabetes mellitus and the context of Sudan, tuberculosis and diabetes health structure, the framework for public health approach. Next. I think this was covered by others, but we are clearly off track to meeting the NTB strategy. Still, there are 10 million new active cases and 1.5 million deaths next. This is the overview of progress towards global targets. The center of each circle shows the target, and the color coding illustrates the progress made, and the text to the right of each circle quantifies the status of progress. As you can see, the targets for reduction of TB incidence is 20%, for deaths is 35%, and catastrophic cost is 0%. And again, we are the red figures show you where we are now. When we come to progress towards targets set by the United Nations level meeting on progress again is lacking. 14.1 million people were treated with TB, and the target was 40 million. 6.3 people were started on TB preventive treatment, and the target was 30 million. Funding for TB prevention, diagnosis, and treatment is 6.5 billion, 50% of the target, which was 13 billion. And again, as you can see, funding for research is less than 50%. And without funding, TB, we cannot reach the targets for TB. And of course, we all know that diabetes and non-communicable diseases are underfunded. Next, please. Next. The TB burden in Sudan is, is like a moderate burden country. As you know, the global is 133 per 100,000. Mortality in Sudan is 11 per 100,000. The estimated number of TB cases is 30,000. The notified is 20. And so Sudan has a gap of 10,000 that they need to reach and put on treatment. 67% is a success, the case detection, and the success rate is range between 80 to 82. This is clearly, again, from this slide that the females' accessibility needs to be looked into. And children, we are finding 10% of the children, but tuberculosis in children was not a high priority for ages. The prevalence of MDR, the new TB patients is 2.3, and previously treated is 9.7. And it's like a pilot because Sudan is reaching only 172 out of the 1,100. Next, please. This is a method for estimating the TB incidence, the prevalence surveys, case notification and standard adjustment, and case notification and expert opinion and the inventory. And Sudan was lucky to be among the countries that were managed to do the prevalence survey. Next. And the survey and the surveillance data showed similar age group distribution. The highest prevalence is among the productive age group, 25 to 34, which is similar to many developing countries. Next. The program in Sudan is well established. It's a population of 40 million, and they have 340 TB management units to provide diagnosis and treatment and services in our 18 states. DOTS all over was announced in 2002, and funding is basically domestic with resources from Global Fund and other for NGOs. Norway has appreciable input in the TB program in Sudan. There is one national reference lab that does DST and molecular testing, 5 zonals, and there is a plan that gene expert expansion as first diagnostic test, as was announced by the NTB strategy. Next, please. Globally, TB control strategies, as you all know, moved from control to elimination, from DOT strategy to NTB strategy, and recognize the importance of partnership, commitment, and leadership, so a little bit late. Next. I will not go into the strategic objective, but there is good reason to think that what they said they will do, because there was a review by Sinwan and myself in May 2020, and they did reach the case detection and success rate. They have to work a little bit on the HIV testing to meet the targets. Next, please. the previous speakers touched on the global, prevalence of diabetes mellitus. So the context of Sudan, Sudan is part of the MENA countries where there are Middle East and North Africa. I think all of you know what is MENA. 55 million people with diabetes. Sudan shoulders 3.6 million, and there are 30,000 deaths every year and this year. Next, please. This slide is very important, I think, because I tried to look on the consequences of poverty and health priorities and political involvement, and the consequences of poverty on health services and quality of care. So health priorities and budget allocated to communicable diseases in most of our settings, insufficient awareness of diabetes mellitus, no political commitment for proper diabetes care. Majority of patients have no health insurance, and there are interruption of essential drugs, poor affordability and accessibility. The consequences on health services, no or poor organization of clinical services for NCDs, including diabetes. Unstructured, unmonitored clinical care is the norm. Complications are not prevented, recognized, or treated. Lack of trained health workers and guidelines adoption and replication is suboptimal, and no reliable information about incident cases, prevalent cases, treatment outcomes, and hardly any of the, the non-communicable diseases programs really follow the cohort analysis. Next, please. And diabetes healthcare structure is like this. Basically, it is specialized care, exists in big cities and university hospitals. But Professor Muhammad Ali Tom and others are trying to have the integrated NCD clinics together with the World Diabetic Federation and basic primary care facilities. They did achieve all what is appearing in the slide: 30 diabetic care units, integrated NCDs clinics, and basic primary care. Basically, we think, the TB people, I mean, when I say we think that the diabetes people really need to put their diagnostic facilities and register books at the district level. Next, please.
We have a minute left, Asma.
Okay, I'm finishing. So this is a collaboration with the Diabetic Federation. They have different packages. I picked for you 1, 3, and 6. And one is diabetes care promotion. They have a lot of mobile clinics, and they did this actually in diabetes. So there is good ground where we can move to the bidirectional. Next, please. Next. And bidirectional screening, 2 packages: screening of patients with TB and screening with patients with diabetes mellitus. And Professor Yan touched on this. Next, please. What did we do? As I said, it's very early. A national stakeholder meeting was held in Khartoum, 2017. Collaborative framework reviewed. Broad guidelines for how the screening should be performed was worked out, and 4 sites were picked. Next. EpiLab and Sudan has good, acumen of how to launch these type of programs. This is the asthma program, which is an NCD. Every patient has a register, has a card, an ID card, and all this is taken into a register book. Next. And we managed to reduce the hospitalization and the ER by launching this program. The funding was by the World Bank. Next. Most important that the patients improved, and we shifted the severe and moderate to mild and intermittent. And next, and I think it's the last slide. And we use M-Mobile for NCDs like asthma. We're telling the patients how many puffs he needs to have and when is his follow-up. And next. And this is my last slide. I took this slide from the WHO report, and Sudan is one of the countries that is using mHealth in cervical cancer, diabetes, and TB and tobacco. And the EpiLab is doing health education and promotion. There is good ground, where we can do the bidirectional screening. And thank you.
Thank you for that rapid overview, Asma. Thank you very much for that. So we have about 2 minutes left. Are there some burning questions that people would like to ask to any of the last speakers? We've lost Dr. Nieves, had to go to work, but any quick questions or comments from anyone before we finish? Dr. Jan, if you would like to give us some closing words and any key issues and impressions from you, Dr. Jan, that would be helpful. Thank you.
Yeah, thank you very much. I think today the webinar, so all the speaker give us a very rich knowledge and overview and experiences in the bidirectional screening of the two disease. We have gone a lot of impression that a lot of activity is happening and a lot of idea raised by our speaker and participants. I would suggest we will keep this momentum moving forward, and we'll share the idea, experience from time to time, as we all have the communication address in the slides and in the routine communication. We encourage the people communicate each other for any of the question at any point of time. So thank you again for this opportunity and a wonderful discussion and presentation from all of you. I think I will hand it over back to our chairperson, Helen IOC.
Thank you very much, Dr. Jan. I think that was a good summary, and we are absolutely on time. So I just wanted to let you know that all the slides will be available on the TB Multimorbidity Network website. And please do have a look at those, and please do be in touch. Sign up to join the network, and we can let you know about future events and the work we are doing. And we're very happy to link you up with speakers if you have issues and questions you'd like to take forward. So it just remains to say a very big thank you to all of our speakers for some really rich presentations, and I think we have a really good overview of many of the key issues. So thank you so much for all of your time and your participation, and thank you for joining us, and we look forward to the next TB Multimorbidity Network event. Thank you very much.